Now we are discussing that how should massive antepartum hemorrhage be managed and who should be included in the resuscitation team. So the answer is the massive antepartum hemorrhage should follow locally devised multidisciplinary protocols for massive obstetric hemorrhage. The management team should include a consultant obstetrician, anesthetic, hematologist, midwifery labor ward coordinator, laboratory staff, and portering staff should be alerted at that call. And with that, additional help from the other specialties like hematologists, vascular surgeons, radiologists. Senior staff should be involved as early as possible and should have appropriate experience. A multidisciplinary hemorrhage protocol should be available in all units and be updated regularly. I repeat, consultant obstetrician, anesthetic, hematologist, midwifery labor ward coordinator, laboratory staff, and portering staff should be alerted. And other specialties should help when needed, including hematologist, vascular surgeon, radiologist. Senior staff should be alerted and should be involved and should be having relevant, appropriate experience. What blood and blood products should be ordered and made available for women with antepartum hemorrhage? Uh, in, uh, in the management of military trauma, a decrease in coagulopathy and improved survival is reported with FFPs to packed red cell transfusion ratio of 1:1 to 1:1.4, like 1.5 red blood cell transfusion to the fresh frozen plasma ratio of 1. And the women who are transfused with packed red blood cells developed acute tubular necrosis more often than the women who were given whole blood. And while pulmonary edema was more commonly seen in women um, who were given whole blood. So we have to weigh and balance with the risk of acute tubular necrosis to the pulmonary edema while choosing the blood type. Now coming to the question, how should the woman presenting with antepartum hemorrhage who develops a coagulopathy will be managed? And in women who have experienced a massive blood loss or major eruption, the development of a DIC should be considered. Clotting studies and platelet count should be urgently requested and advice from a hematologist should be sought. Up to 4 units of fresh frozen plasma and 10 units of cryoprecipitate may be given while awaiting the results of the coagulation study. Then comes up the question, how should the woman presenting with an antepartum hemorrhage who is taking anticoagulant therapy be managed? Women receiving anticoagulant therapy, if they feel face any sort of vaginal bleeding, They should not take any more doses of the anticoagulant medication and should attend the hospital urgently. Be assessed on admission and further doses should only be administered after consultation with the medical staff. If a woman develops a hemorrhagic problem while on anticoagulant therapy, treatment should be reviewed urgently and expert hematological advice should be sought. And women who are considered to be high risk of hemorrhage and in whom continued heparin treatment is considered essential should be managed with intravenous unfractionated heparin until the risk factors for hemorrhage are resolved. In women whose pregnancy is complicated by the antepartum hemorrhage, how should the neonate be managed and be by whom? In women with major or massive antepartum hemorrhage may result in fetal anemia or fetal compromise. The neonate should be assessed by a senior pediatrician or neonatologist. In minor antepartum hemorrhage, clinical judgment should be used. With continuing hemorrhage, it would be appropriate to request pediatric support at the time of delivery. In women with major antepartum hemorrhage, abruption and vasa previa is there. The obstetrician should ensure that in cases of vasa previa, the umbilical cord is clamped as soon as possible after delivery, leaving the longer part attached to the neonate and the umbilical artificialization is facilitated as required. Placenta previa. Anterior placenta previa that necessitates incising the placenta at the time of cesarean section is an indication for attendance by an experienced pediatrician or neonatologist. Anterior placenta previa that necessitates incising the placenta at the time of cesarean section is an indication for attendance by an experienced pediatrician or neonatologist. Minor antepartum hemorrhage, it would be appropriate to inform pediatric staff of the anticipated delivery and clinical judgment of these circumstances is necessary. How should the woman be then extremely preterm pregnancy, like from 24 to 26 weeks of gestation and antepartum hemorrhage remains regardless of the gestation? The mother's life should take priority. She should be resuscitated and stabilized before any decision is made regarding delivery of the baby. A senior pediatrician or neonatologist should be involved in the counseling of women when extreme preterm birth is likely. And conservative management is usually appropriate when APH occurs in extremely preterm pregnancy, less than 26 weeks of gestation, and the mother's condition is stable. Conservative approach is employed in cases where there is mild antepartum hemorrhage in the extreme preterm pregnancy and the maternal condition is stable. So conservative approach is advisable and appropriate. And when bleeding is considered life-threatening for women or when there is evidence of cardiovascular compromise that fails response to resuscitation, consideration should be given to the delivery of the fetus. At these gestations, experienced neonatologists should be involved in the counseling of the woman and her partner. The use of practical clinical guidelines in these situations aids consistency and promotes informed, supportive, and responsible counseling. What are the postnatal issues that need to be addressed in women whose pregnancies are complicated by antepartum hemorrhage? The postnatal management of pregnancy complicated by major massive antepartum hemorrhage would include thromboprophylaxis, bracing, and clinical incident reporting. The postnatal management of pregnancies complicated by major or massive antepartum hemorrhage should include thromboprophylaxis, debriefing, and clinical incident reporting. Following a major antepartum hemorrhage, when the outcome for either the mother or baby was suboptimal, it is important that an experience of petition debrief the woman and her partner. The visit should take place at the earliest possible time following delivery when the woman is able to comprehend and communicate. The event should be discussed and the woman and her family given the opportunity to ask questions. A follow-up appointment 4 to 6 weeks following birth should be offered and contact numbers for access to medical and psychological support should be provided as appropriate. When where the APS has resulted in fetal demise, good communication between transplant and general health practitioner and community midwife is crucial. Hemorrhage and blood transfusion are risk factors for venous thromboembolism. Therefore, thromboprophylaxis should be commenced or reinstituted as soon as the immediate risk of hemorrhage is reduced. Women at high risk of further hemorrhage or women with continuing hemorrhage and in whom thromboprophylaxis indicated may be more appropriately managed with unfractionated heparin or graduated compression stockings are to be given. What is the role of obstetric skill drills to improve the management of antepartum hemorrhage? And the management of antepartum hemorrhage should be included in obstetric skill drills, and these drills are also now one of the requirements in the new maternity clinical negligence scheme for trust standards. And management of obstetric emergencies increases midwives and doctors' knowledge. Skill drills should ensure all members of staff, including those involved in the blood transfusion services, how they know exactly what to do, ensuring that appropriate blood products are delivered in the labor ward. In the labor ward. A multidisciplinary approach to state treatment should promote effective team working and ensure prompt and efficient management in such cases, in such emergencies. The auditable topics are the administration of corticosteroids to women presenting with APS less than 34 weeks of gestation, administration of anti-D to non-sensitized RSV negative women presenting with antepartum hemorrhage, administration of anti-D immunoglobulins to non-sensitized RSV negative women presenting with APS, percentage of women with antepartum hemorrhage, recurrent episodes of minor antepartum hemorrhage in major APS that have resolved for unexplained antepartum hemorrhage that occurred for several serious groups and of the first stage of labor in women who had a major APS management of the third stage of labor who had a major antepartum hemorrhage. Percentage of women with antepartum hemorrhage result in an APS management of unexplained APS occurred for serious appropriate training for multidisciplinary team. Now we are going to discuss the principles of management of massive antepartum hemorrhage. And the blood loss is greater than 1,000, and there are signs of clinical shock. The personnel required again is repetition, experience made 5, middle grade obstetric consultant and a nurse consultant, call anesthetic middle grade and a nurse consultant, a clinical hematologist on call, a nurse blood transfusion laboratory, and call porters for delivery of the specimen or blood. Designate one member of the team to record events, noise, drugs, and vital signs. Events, noise, drugs, and the vital signs. Initial management is again ABCD. High concentration of the oxygen, 10 to 15 liters per minute via face mask to the administered. Use the circulation and establish two 14 kH IV lines. 20 ml blood loss sample should be taken and sent for diagnostic test, including full blood count and assessment of fetal internal hemorrhage if RSV negative. Coagulation screen using electrolytes and the cross-match for poisoning. And these assessment of the fetus and decide on delivery. The four pillars of the management include communication between all members of the multidisciplinary team, resuscitation, monitoring and investigation, and arrest bleeding by arranging delivery of the fetus. Communication, resuscitation, monitoring and investigation, and arrest bleeding by arranging delivery of the fetus. Now coming to the principles of fluid replacement and administration of the blood product. Basic measures for hemorrhage up to 1000 ml with no clinical shock is the IV access 14 gauge cannula, only one can be good. Commence crystalloid infusion. Now coming to the full protocol of the massive hemorrhage where there is clinical shock and ongoing blood loss is more than 1000. We have to assess the AIV, assess breathing, evaluate for the circulation, oxygen mass, time mass at 10 to 15 liters per minute. IV access 14 gauge cannula, 2 should be inserted. Position left filter tilt, keep the woman warm using appropriate available measures. Transfuse blood as soon as possible. Until blood is available, infuse up to 3.5 liters of the warmed crystallized Hartmann solution, 2 liters, or colloids 1 to 2 liters as rapidly as required. The testing treatment available should be used to achieve rapid warm infusion of fluid. Special blood filters should not be used as a flow infusion. Special blood filters should not be used as a flow infusion. Fluorotherapy and blood product transfusion. Crystalloids up to 2 liters Hartmann solution. Colloids 1 to 2 liters colloid until blood rise. Blood flow fast if blood clot is not unavailable and the clinical situation is urgent if unclean process group specific blood or blood negative. Blood consider the use of the red cell sizes is available. FFP is 4 units of FFP, 12 to 15 ml per kg for total 1 liter. 15 ml per kg, total 1 liter. For every 6 units of red blood cell or if prothrombin time for APCT are greater than 1.5 into mean control. So fresh frozen plasma है अब 1 liter तक देना है 4 grams of FFP, blood है, cross है, available. and platelet concentration, if platelet count is less than 50, then we have to keep the platelet concentrate and drive percentage. If 5 milligram is less than 1 gram per liter. With continued massive hemorrhage and while creating dilation studies up to 4 units of hyperspace and 10 units of hyperspace, 2 packs may be given into the body. Apply clinical judgment in each situation. The main therapeutic goal of the management of massive blood loss is hemoglobin. The therapeutic goal of management of massive blood loss is to maintain hemoglobin more than 8 grams per deciliter, platelet count more than 75, and prothrombin time less than 1.5 into mean control, and activated partial thromboplastin time less than 1.5 into mean control, 5 more than 1 grams per liter.